Hello, our last lecture in the course is about surveillance and screening in public health. We will review some concepts of public health surveillance and describe the attributes of a surveillance system. We will also describe the characteristics of ideal screening tests and we'll learn what sensitivity, specificity, and predictive values tell us about screening tests. We will finish this lecture reviewing methods and bias when assessing the effectiveness of screening programs. The Public Health Agency of Canada defines surveillance as the ongoing, systematic use of routinely collected health data to guide timely public health action. To obtain surveillance data it needs, the agency works in concert with other federal departments and agencies and other levels of government, as well as health professionals, hospitals, and laboratories across the country. We do surveillance for many reasons. For example, to describe the epidemiology of a health event, to describe and detect outbreaks and epidemics, to monitor changes in health status and health practices, and to evaluate public health programs. When doing surveillance, not all diseases are equal. Diseases are selected to be notifiable in surveillance programs because of the public health importance of the problem or because there are existing resources to prevent, control, or treat the health problem. Notifiable diseases can also be reported at the aggregate level or individual level. The Public Health Agency of Canada is the federal organization responsible for the surveillance of infectious diseases. It was created in 2004, following the outbreak of SARS in Canada. The chart here describes the process in which surveillance information of infectious diseases is communicated to the Public Health Agency of Canada. Once an individual feels ill and seeks medical care, the health professional makes the diagnosis of infectious disease. After this, the sample is sent to the lab makes a diagnosis, and then informs the health authority. The health authority reports the province, and the province informs the public health agency. On the other hand, the health professional also makes a separate report to the regional health authority, which informs the province, and then the report lands at the public health agency. A good surveillance system should be sensitive, meaning that it should have the ability to detect outbreaks. It should be timely, representative of the health event, acceptable, simple, and flexible. Surveillance might be classified in active, passive, and sentinel. In active surveillance, you search out the cases of disease. The organization conducting surveillance initiates procedures to obtain reports, such as regular telephone calls or visits to physicians or hospitals. The method is costly and labor-intensive. However, it provides a more complete estimate of disease frequency. In passive surveillance, the system waits for cases to be reported. Organizations conducting surveillance do not contact potential reporters and leave the initiative for reporting to others. Passive surveillance is advantageous because it occurs continuously and it requires few resources. However, it's likely to underreport disease frequency. Finally, sentinel surveillance uses pre-arranged sample of source data who have agreed to report all cases rather than the entire population. Passive surveillance is simple in nature. It occurs continuously and it requires few resources. However, the information that produced might be quite incomplete. On the other hand, active surveillance is more expensive but more accurate as it ensures a more complete reporting. Here are some examples of surveillance in Canada. The IMPACT Canadian Immunization Monitoring Program Active is a pediatric hospital-based national active surveillance network for adverse events following immunization, vaccine failures, and selected infectious diseases that are or will be vaccine preventable. IMPACT is administered by the Canadian Pediatric Society. On the other hand, the prostate cancer surveillance by Prostate Cancer Canada is regularly monitored for signs of progression of prostate cancer. The Canadian Perinatal Surveillance System is a passive surveillance system of all kinds of perinatal defects. Sentinel surveillance is a form of passive and active surveillance in which selected clinicians gather data and pass them on to those responsible for the surveillance. The notion of sentinel refers to keeping watch for particular diseases of interest. For example, the Canadian Primary Care Sentinel Surveillance Network links selected family health teams by electronic record surveillance system. This can be used both to report rare events, such as side effects that they observe from influenza immunizations, and to help improve the quality of care. For the Tarrant Viral Watch, the goal is to detect influenza-like illness clinically as it occurs in the community and to measure influenza virologically in the lab. Data is collected by volunteer physicians and nurses and is compiled prior to being forwarded to Alberta Health, the Public Health Agency of Canada, and the WHO. Syndromic surveillance is used for early detection of outbreaks, to follow the size and spread of outbreaks, and to monitor disease trends. It uses data in real time for immediate analysis and provides this feedback to those in charge of the investigation and follow-up of potential outbreaks. Dissemination is an important component of surveillance, and some considerations need to be taken into account before disseminating surveillance data. For example, the public release and display of data should be planned and provided with accurate display of tables and data. To communicate surveillance information, you need to keep in mind who the end user will be. It's important to limit the technical jargon and provide a clear indication of the data and limitations. Finally, you should use a variety of communication methods to convey this information. We have reviewed some important concepts about surveillance. In summary, surveillance is information for action and is a great public health tool to guide prevention and treatment programs. Now we're going to talk about screening, and before we do so, I would like to make a quick review of some key steps in the natural history of diseases to understand what screening is good for. Natural history of disease follows a sequence in which there is a biological onset, a phase that is detectable by testing, then the symptoms begin, the condition is diagnosed, and finally it becomes disabling unless we intervene in the course of the natural history of disease. Screening is the process of detecting disease early with the intention of intervening to halt its progression. Preventive measures can be applied at any stage along the natural history of a disease with the goal of preventing further progression of the condition. Primary prevention seeks to prevent the onset of specific diseases by risk reduction. That means by altering behaviors or exposures that can lead to disease. Some examples include smoking cessation and vaccination. Primary prevention reduces the incidence of disease by addressing disease risk factors or by enhancing resistance. Secondary prevention includes procedures that detect and treat preclinical pathological changes and control disease progression. Screening procedures such as mammography to detect early-stage breast cancer are often the first step leading to early interventions that are more cost-effective than intervening once the symptoms appear. Once a disease has developed and has been treated in the acute clinical phase, tertiary prevention seeks to soften the impact caused by the disease on the patient's function, longevity, and quality of life. Examples of this include cancer treatments seeking to extend survival and improve quality of life. Screening is the process by which unrecognized disease or defects are identified using tests that can be applied rapidly and to large numbers of people. Screening tests distinguish healthy people from those who probably have the disease. Screening is an initial examination and it's usually non-diagnostic, so it requires appropriate investigative follow-up and treatment as needed. There are different types of screening. Mass screening is the screening of a whole population or a subgroup of the population. It's offered to all, irrespective of the risk status of the individuals. High risk or selective screening is conducted among risk populations only. Multiphasic screening is the application of two or more screening tests to a large population at one time instead of carrying out separate screening tests for single diseases. Screening tests assume that earlier diagnosis will lead to earlier and more effective treatment that will decrease the adverse events of a disease and improve survival. A disease must have certain characteristics in order to be appropriate for screening. The disease should be an important public health problem. The natural history of disease has a suitable window of opportunity for screening, and effective treatment is available. Treatment is more effective at an early stage, and the last condition is that a suitable screening test should be available. A screening test must be economical, convenient, relatively free of risk and discomfort, acceptable to a large number of individuals, and highly valid and reliable. A few examples are provided here, such as serology tests for HIV, hepatitis B, and TB, mammograms for breast cancer detection, pap smears for cervical cancer, blood pressure monitoring and cholesterol screening for heart disease, and vision test for glaucoma. Reliability of a screening test is the extent to which the test will give the same result on repeated measurements. Validity means that a test is measuring what it's supposed to measure. Sensitivity and specificity are measures for validity of a screening test. Validity is measured by sensitivity and specificity. These terms, as well as others, are best illustrated using a conventional 2x2 table. In cell A, we enter information of those in which the test correctly diagnosed the disease, as defined by the gold standard. In other words, the test is positive, so the gold standard is. These are the true positives. In cell B, we enter those who have positive results for the test but do not have the disease according to the gold standard. The new test has wrongly diagnosed the disease. These are false positives. In cell C, we enter information of those who have the disease according to the gold standard but have negative results with the test in question. The test has wrongly labeled a diseased person as normal, and these are false negatives. In cell D, we enter information of those who have no disease as defined by the gold standard and are also negative with the new test. These are true negatives. We will define these terms better in the second part of our lecture.